We're going to get restarted, and I'm going to ask Dr. Rob Garofalo from Lurie Children's Hospital in Northwestern to introduce the next speaker, and we'll continue.
Hi, good morning. I'll make this quick because we're a little bit behind, but I'm excited about this next cadre of speakers, starting off with Dr. Brian Mustanski, who's an associate professor in the Department of Medical Social Sciences at Northwestern and the director of the IMPACT program, and he's going to be talking about Syndemic among gay, bisexual, and transgender youth in Chicago.
Thanks, Rob. I'll be sharing some of the work that Rob and I have been doing together for the last few years, and I just want to start by thanking Rich for organizing this. It's really amazing to see all of these people from different institutions in Chicago coming together for this discussion, and I think it's already been really productive, and I know I've already learned a lot, so I'm looking forward to the rest of the day. I'm going to be talking about bringing more of a biobehavioral perspective to the discussion as well, and talking about some considerations for sort of behavioral aspects of the epidemic that we might want to consider as we think about moving towards a cure. As Rob mentioned, I'm the director of the IMPACT program. For people who don't know, it's a program at Northwestern focused on advancing LGBT health. It's a collaboration between Northwestern University and the Center on Halsted. We run the majority of our projects out of the Center on Halsted. And the mission of the IMPACT is to conduct translational research, which means we're doing projects that are really moving from science into application. I guess there's a lot of animation on this slide. I'm moving quickly because I know we're a little behind time. So we were fortunate to hear from Nick already about the local Chicago epidemic, but this is some data from the Center for Disease Control around the national HIV epidemic from 2010. And what we see here is that about 70% of HIV infections in 2010 occurred amongst these groups of men who have sex with men, the largest number being white MSM, followed by black MSM, and then Hispanic and Latino MSM. So together, MSM are representing 70% of the national HIV epidemic in terms of new infections. And of course, nested within that are racial disparities. We know there's a larger number of white MSM being infected, but of course they represent a larger proportion of the population. So when you factor in population size, the rate of infections is higher amongst black MSM than white MSM. Also nested on top of this is some developmental considerations. So this is also national data from 2008 through 2011, and we see the number of new HIV diagnoses by age group amongst MSM. And we see that the largest number of new infections was among 25 to 34-year-olds, followed by 13 to 24-year-olds. In addition, 13 to 24-year-olds represent the group that's showing the largest increase in new infections. They showed a 26% increase in new infections over that 4-year period. That's on top of increases that had been seen in the prior 4-year period as well. So what is a syndemic? That's what I'm going to be talking about today in my time. In terms of sort of understanding the co-occurrence of epidemics that occur in particular populations, the concept of a syndemic was created. And essentially, it's this focus on multiple co-occurring diseases, and it differs from the traditional biomedical approach of treating each disorder as a distinct entity. So let me just sort of illustrate that. So in medicine and often in clinical psychology, we use the concept of comorbidity, which is that we think of two separate diagnoses that tend to co-occur more frequently than might happen by chance. And the goal of research on comorbidity is really to understand if these are just two manifestations of the same underlying illness, if one is causing the other, if the comorbid condition is a unique disorder, or if there's just some measurement error that might explain the co-occurrence of the two disorders. A syndemic perspective really comes at it from a different angle, which is really the sense that there's these multiple connected co-occurring epidemics that occur in marginalized communities, that there's social determinants that are driving these co-occurring epidemics, and that as you accumulate multiple epidemic conditions, they have an additive or interactive effect on overall health. So having two syndemic conditions is worse than just having one syndemic condition, and it can be worse than just the additive contribution of sort of 1 + 1 syndemic condition. This is sort of illustrated by the Sufi saying, you think you understand two because you understand one and one, but you must also understand and. And that's really been a big focus of the work that I've been doing over the last decade, is understanding the co-occurrence of health issues in different marginalized populations. In the sort of construct of syndemic as it's been applied to men who have sex with men has focused on these four issues of drug use, alcohol use, mental health, most frequently anxiety and depression, and sexual risk-taking and its consequences. What we know is that there are shared social determinants, things like marginalization, lack of access to same-sex marriage, bullying in schools at early ages, lack of parental support. These things create a trajectory of health issues that can accumulate throughout the life course. So we know that these sort of social determinants have broad impact across these range of outcomes. And that these syndemic conditions then increase risk for these adverse outcomes of things like HIV, sexually transmitted infection, and suicide. These have been documented in numerous studies. But when we start thinking about the concept of HIV cure, it also becomes relevant to think about how these syndemic conditions impact things like HIV care. How do they impact the continuum of care, having these syndemic conditions in terms of their impact on HIV testing, in terms of linkage to care, in terms of medication adherence? Because if the goal of a cure approach, what we're hearing already this morning suggests we need to identify people very early, early in their infection, and we need to have them maintain excellent adherence to medications, these syndemic conditions are going to be very important in terms of all of those steps of the cascade of care. And this is just an illustrative example of the sort of epidemic of substance use, which is one of the core components of the syndemic amongst men who have sex with men. So this is amongst adolescents. This is a meta-analysis published in Addiction, comparing the odds of cigarette use, 2.7, alcohol use, 2.5. When you get to drugs like injection drug use, cocaine, much higher odds of use of those drugs amongst gay and lesbian adolescents compared to their heterosexual peers. So we know that these syndemic components, these epidemics, are occurring more frequently amongst people in the LGBT community. We know they begin early, and we know that they have effects throughout the life course. Rob and I published a paper in 2007 using some cross-sectional data to look at the co-occurrence of these epidemics in adolescent men who have sex with men. And what we found is the significant co-occurrence of binge drinking, street drug use, regular marijuana use, psychological distress, experiencing sexual assault, partner violence, unprotected sex, or condomless sex, and the association with HIV status. And in fact, when we sort of quantified this and sort of added up the number of syndemic conditions that people had, we saw that even after controlling for race and socioeconomic status and age, that each syndemic condition increased the odds of being HIV positive by 40%. So there's a dramatic association between these syndemic conditions and likelihood of becoming infected. So they impact likelihood of infection as well as the ability of people to maintain adherence to treatment. Of course, all of this work has been cross-sectional, or most of this work has been cross-sectional so far, and what we're very interested in is moving it into a developmental lens. And I thought I would show an interesting example of this from a paper we published in 2013 on another sample, which was low-income African-American youth living in public housing in the South. And what we did is we looked at sort of trajectories of these risk behaviors across adolescence. This was data from 12-year-olds to 18-year-olds. And you see that you can put people into groups in terms of their sexual risk behavior, their substance use, and engagement in other risk behaviors, conduct problems, for example. And we identified 3 different groups. A normative low-risk group, this is where most of the adolescents fell. They weren't engaging in most of these risk behaviors. You saw a group of adolescents that was increasing their risk-taking across adolescence, and we have a group that is sort of adolescent limited. They're sort of experimenting with these risk behaviors during adolescence. And the reason I'm pointing this out is because of its implications for understanding HIV and sexually transmitted infection, is that what we found, one of our major findings was that in terms of risk for sexually transmitted infections, the period of risk compared to the normative group was really developmentally linked to these trajectories. So if you look at these increased risk takers and compare them to the normative group and the adolescent conduct group, they're actually very similar in their unprotected sex or their risky sexual behavior. It's going to take me a while to get that transition. I'm trying. But they're very similar in terms of their engagement in condomless sex. Where they differ is in their substance use and their conduct problems. And it's the substance use and conduct problems that are predicting sexually transmitted infections, not unprotected sex. Or, geez, that's hard. So anyway, what I'm saying is these epidemics are interrelated, and you need to understand all of them to start understanding infection risk. We're now studying this in young men who have sex with men. Rob Garofalo and I are running a project called Crew 450, where we're following 450 young men from ages 16 to 22 to understand the development of these trajectories of these issues. It's a very racially diverse sample. 7.6% of them were HIV positive at enrollment. At our one-year estimate of incidence is 5.4% annual incidence in this cohort. And we're using this approach to look at things like racial differences. And what we know when we look at racial differences, so we started out earlier talking about this, racial differences in the HIV epidemic amongst men who have sex with men. And one of the things that's very interesting about these racial differences is they're not driven by individual behavior. When we look at African American youth and African American adult men who have sex with men, and we compare them to white men who have sex with men, they're not engaging in any more condomless anal intercourse. They don't have higher rates, they don't have lower rates of condom use, they have fewer sex partners, they have less substance use. So the African American men essentially are doing everything right, or at least as compared to the white men, but they're getting infected at a much higher rate. And we think that networks might be one of the explanations, one of the things that's driving that. And so, we've started to look at network factors like concurrency of partners, characteristics of the sexual partner, the mixing, sort of who's having sex with who, the density of those connections. And we got a supplement from the NIH to study this in a smaller group of these 450 men, where we did a social and sexual network interview. And I'm just going to show you a subset of that data to sort of highlight the importance of also starting to think about things like network factors. We'll be hearing more about that from John in terms of prevention and treatment. So we did this network interview where people actually drew out their sexual networks. They gave us the first and last names of all of their sexual partners. We drew them out and on the board, and from that we converted it into a sexual network. What we found is no differences in the number of sex partners in the past 6 weeks. These are racial differences. No difference in unprotected vaginal or anal sex. No differences in having any unprotected sex between the black and white young men who have sex with men. So again, individual behavior is not driving this epidemic. What we found is some age differences in terms of their partners. The black young men, the average age of their partners was nearly 2.5 years older than them, whereas the white young men, the average age of their partner was only about 1 year older than them. So we're starting to see differences not in individual behavior, but in the characteristics of the partner and the network that are possible drivers of the epidemic. We were very fortunate that Chicago Department of Public Health gave us a lot of excellent STI HIV epidemiological data by neighborhood amongst young men. And one of the comparisons that we were then able to do is we actually mapped the residential location of the sexual partners that these men had. And what we found is that almost 40% of the black young men had a sex partner who's living in one of the highest HIV, in one of the neighborhoods with the highest rate of HIV in Chicago, whereas only 5% of the white young men were having sex partners who were living in high prevalence neighborhoods. So again, we start seeing network and geographic characteristics that are driving this epidemic, not individual behavior. We've also found differences in sexual network density. We find that white young MSM have lower density in their sexual networks as compared to the black and Hispanic participants, which means their networks are essentially less interconnected, more connected networks allow for diseases to be spread more quickly within that network. So it is, again, not about individual behavior, it's about network characteristics. It sort of summarizes across these different network characteristics, and consistently we see that the Black young MSM have the network characteristics that we know from prior research drive epidemics. So in terms of next steps, I'll just leave you with some things that we're sort of working on pulling this all together. So we've, over the last sort of decade or so, we've had a lot of research on individual behavior, we've had a lot of biomedical research, we've had some network research, we've had some dyadic research, and we were very happy that last week we started a new UL1 grant from, that was funded by the National Institute of Drug Abuse to create this very large dynamic dyadic network cohort of young MSM that we'll be now following at least for another 5 years. Some of them, at the end of the study, will have followed for 10 years in our cohort. The sample size is projected to be around 1,300 by the end of the study. And it's going to be integrating all of these perspectives into the same study. We're going to be looking at biology, development, dyadic, network, and structural factors all in the same cohort over time. And this cohort is going to serve as a platform for future biobehavioral research. Rich has already received an AMFAR grant that's going to be using some of the participants from this cohort to look at recently infected individuals. So we're very excited about this, and I'm happy to sort of answer any questions about it at the end. It's going to be hybridizing 2 of the existing studies that we have called Project Q2 and Shy Guys. So let me just end by thanking NIDA for providing funding for these projects, Rob Garofalo, the co-PI of the parent grant, co-investigators on the project as well. So thank you.
All right, next is a good friend, Sybil Hosek from Stroger Hospital, who's going to be talking about PrEP in adolescents.
All right, and I'm going to see if I can figure out, touch screen. Wow. Hi, everybody. Thank you very much for having me. I want to thank Rich and for Brian for organizing this and for inviting me to come and talk. Switch gears a little bit and talk about one of our newer prevention modalities, which is PrEP. I'm going to talk a little bit about what is PrEP, but in the to be responsive to the time limits that we're on, and then we're a little behind schedule. I'm going to fly through some of the current PrEP research, but then really focus on what's going on here in Chicago, where we should be going next with PrEP, and then what are the synergies between PrEP with testing and cure. So most of you in the room know that in July of 2012, the FDA approved the first medication for the prevention of HIV. That medication was Truvada. Happened to be a medication that we were very experienced with in terms of treatment, and one that was approved for both adults and pediatrics, and that we had a long safety profile for, one that most people felt very comfortable with. And I think that's important in terms of where we go from here with next generation PrEP. But for right now, Truvada is the one and only medication that we have to prevent the transmission of HIV. The trials that were conducted to prove the efficacy of Truvada as PrEP were conducted all around the world. I think there was over 20,000 people involved in those trials. And again, many of you may know this data, but let me just quickly go through and look at sort of the seminal trials that the FDA considered when approving Truvada for PrEP. And those are the top 3 trials there. Partners PrEP, which was looking at serodiscordant couples, the IPREX trial looking at MSM and trans women, and TDF2, which was a CDC trial looking at young heterosexual men and women. And all of those showed strong overall efficacy. And when I say overall efficacy, I mean that with the intent to treat models. But subsequent analysis, sub-analyses in all of these protocols looked specifically at individuals who had detectable drug in their system and found that when you actually had drug detected in your system, the risk reduction was very, very high. And we're talking about over 90% for most of the trials. So really strong evidence. Subsequently, we've also had the Bangkok-Tenofovir trial, which is the last one here on the screen, which looked at male and female injection drug users and also had significant overall efficacy as well as increased risk reduction for those, obviously, who were taking the medication and had detectable drug in their system. We still have these 2 outliers, which are the FemPrep trial and the VOICE trial. Both of these trials were stopped due to futility. They both happened to focus on young women, and both were in South Africa. in the end, it really appears, and there's a lot of ongoing qualitative and sociological research trying to figure out what happened. Clearly, there's contextual issues around the reasons why people in impoverished areas may engage in clinical trials, whether or not they think that they're at risk. But ultimately, folks in these trials were not taking the pill anywhere near where they needed to be able to assess efficacy. And so those analyses were futile. I think it's just really important to point out, as John said, there are many ways to protect yourself from HIV, and condoms are just one of them. Condoms have been the gold standard for a very long time, and I am by no means saying that they shouldn't continue to be the gold standard, but we know that there's 50,000 new infections a year, which means that people are not necessarily using condoms. And so what I really want to show you here is that some of these trial results, including treatment as prevention, but also PrEP trial results, show efficacy that's actually higher than traditional use or typical use of condoms among either heterosexuals or men who have sex with men. I think it's really important to recognize that when taken, these products are really highly efficacious and can really make significant change in the epidemic. All of the trials did see some level of drug resistance, but it's important to note that none of that was seen in folks who seroconverted on the studies. The important part is that all of the resistance was seen in folks who were enrolled and started on study drug, but that actually had an undetected acute infection going on. And that's really important because when there was PrEP on board and HIV came into the system, there was never any resistance. But when HIV was already in the system and we took PrEP, then that's when the resistance occurred, and I think that's very important to remember. And the reason probably that there was no resistance among the folks who seroconverted during the studies is because they weren't taking the medication. So there was really no drug on board to become resistant to. Adherence continues to be the Achilles heel of all biomedical prevention trials, and something that the behavioralists are focusing on a lot, and hopefully we'll pay more attention to in upcoming trials. But the discrepancies between self-reported adherence and what was actually found in the trials was significant. And you can see here in some of the trials, particularly the two trials that failed, the FemPrep and the VOICE, the self-report was over 90%. And even in the VOICE trial, folks brought the right amount of pills back to show that they had taken the right amount of pill. They had a vaginal microbicide arm as well, and they brought back the applicators to show that they used them, but they really weren't using them. So there was a lot of effort put into making themselves look like really good participants. And again, I think we have to think about the contextual reasons for why that was, and perhaps the compensation that they were receiving for being part of the trial. So important to remember, but the drug level showed us that they were not taking the drug. So one of the good things that's come out of a lot of this work is that it appears that there's a fair amount of flexibility in the regimen of Truvada for PrEP. The only approved regimen right now is daily oral Truvada, one pill once a day. But what we have seen looking at directly observed studies as well as with the IPREX data, and this comes from Pete Anderson's group in Denver, is that there's a fair amount of protection at 2 times a week, and very good protection actually at 4 times a week dosing. So again, we're not recommending that folks intermittently start to take their pill, but to recognize that there is forgiveness in this regimen, and that even if you're taking the pill 4 times a week, we would estimate that that's still about 96% protection against HIV. So that does bring people to think, well, then how many pills are enough, and are there different ways to do this, and is daily dosing the right way to go, given the adherence issues? And so there are 2 intermittent trials in the field right now. One is the ADAPT trial, HP10-067, which is fully enrolled in Thailand and South Africa, and we're just waiting for the US to catch up. And that's looking at daily dosing versus twice weekly plus a postcoital boost, or 24 hours precoital and 2 hours postcoital. So a variety of different regimens. And Thailand is looking at men who have sex with men, South Africa at women who have sex with men, in the US a combination of MSM and trans. And then the IPREX study in France, which is looking at intermittent or on-demand Truvada. And this is actually a randomized controlled, placebo-controlled trial that's looking at kind of the on-demand is the idea that you take a pill prior to having sex once during the sexual event, and then after the sexual event. So 24 hours before, 1 tab during, so you know, stop, hold on, dose, and then 1 tab within 24 hours after. So again, those trials are underway, and we'll see what those results are. So we're still learning a lot about PrEP, and we really are transitioning from clinical trials into implementation research. We're not sure exactly who's going to end up prescribing it, where it's going to be prescribed. Some of these things have started to become answered, particularly around who will pay for it. There was a lot of concern early on that insurance companies wouldn't cover it, and the AIDS Foundation actually leads a group who's troubleshooting anybody that gets denied access to PrEP through their insurance companies. And so far, nobody has been denied. Every insurance company, some require pre-authorization, some due to some, form error and things like that, it has taken a while to get it through, but nobody has denied it, and that includes Medicaid, and that includes locally county care, which is our affordable care program. So there's definitely access to PrEP, but we still have to kind of figure out what's the best way really to roll it out. And just to be, and we always need to think of the community perspective, this has not been without controversy. I mean, even within the gay community, there's a fair amount of discord around whether or not this is the right approach to prevent HIV. And one of the most outspoken players in this has been Michael Weinstein of the AIDS Healthcare Foundation, who even just recently said, look, this is a party drug. Why are we giving this? Gay men just want to have unprotected sex. Unprotected, not even condomless. And so this is really dividing the community. And we see here, we've seen people called Truvada whore, really stigmatizing something that could be such a powerful prevention tool. And of course, there are campaigns pushing back against it. We have the stigma campaign against Got PrEP. And of course, here, I loved this. This was comparing PrEP to life jackets, which we should not encourage life jackets because they just encourage risky behavior. The only way is to abstain from going in the water. But there has been a fair amount of backlash, but we need to keep up with this and not ruin a prevention option that we might have available. So, again, with all of this in the community and all of the translational and implementation questions that we have, there are many, many, many demonstration projects going on in the United States and around the world. I'm not going to go through all of them, but they are all listed here. And this is data from the AVAC website, which you can get. That's the AIDS Vaccine Advocacy Group. All of the demonstration projects. But suffice it to say, there are many common elements among those trials, really looking at acceptability and uptake, still looking at safety because that's important, but really focusing more on the behavioral aspects and the adherence and the risk behavior, and then what are the best practices for implementing PrEP and the cost effectiveness of it. So let me shift then to tell you what we have going on here in the great but still cold city of Chicago. So first I'm going to talk about a couple of new exciting projects that are going to be implemented in this coming year, both of them out of the University of Chicago with John Schneider as the PI. The first is the SHIP project, which is led by Don Smith at the CDC. It's going to be implemented across 4 cities, and I think that our city may be the first one to get up and going. But this is really trying to look at the natural history of the implementation of PrEP, and they specifically chose federally qualified health centers as the location for these trials. Again, still looking at safety and behavioral response and adherence, but also what the costs are and just the clinical practice of getting people referred, getting them in. One of the really important points about this project for this city is that the rest of the work that's been done in the city has focused predominantly on men who have sex with men. Whereas this project will enroll kind of all comers, including heterosexual women, and including injection drug users. So I think that's very important to know, and thank you to John for letting me know that it hopefully should be starting at the beginning of June. And then another project that was just recently funded for University of Chicago again. John was through the NIMH as a test of a DIS intervention in partnership with CDPH, which is really focused on linking, and that's that critical piece, linking those high-risk negatives to PrEP care anywhere within the city. And that's going to be the primary outcome, is that linkage. And again, all risk groups included, which I think is very important, and then dropping the age a little bit and getting down to 16-year-olds who may be interested. And hopefully enrollment for that will start at the beginning of next year. Howard Brown also has a demonstration project going on. This is funded by Gilead and officially began collecting data last month. And the key component of this is the adherence counseling piece. It's kind of like having a dedicated case manager, but someone who's helping you not only with your adherence, but for applying for patient assistance programs, filling prescriptions, navigating insurance, et cetera. And I'll just say that this is their demonstration project, but Howard Brown currently has, I think, about 200 people already enrolled or already prescribed PrEP outside of this program. But this is going to be a way for them to really capture that data around implementing the PrEP program that will inform projects moving forward. And then I'm just going to talk a little bit about our trials through the ATN 110 and 113. These are the licensing trials where we're hoping to bridge the label of Truvada down to the age of 15. And the FDA was very concerned about getting data in adolescents when they first approved Truvada for PrEP, and also just getting more data on the young age, the 18 to 22-year-olds, because domestically we had, I think, 25 youth under the age of 25 represented in the PrEP trials. So we split these two trials. We have an 18 to 22-year-old cohort and a 15 to 17-year-old cohort. And the primary reason for that was simplification for the IRBs. We realized that the minors, there would be some issues with IRBs, and so we didn't want to hold up the other protocol. But looking at, again, some of the typical outcomes. I'll just show you that we did have some trouble getting the younger age cohort through some of the IRBs. We lost about half of our sites. And these are the sites that enrolled into 113. And I'll just show you a little bit of data. We talk about interest and uptake. I think we had tremendous interest nationwide in PrEP and being involved in PrEP projects. We had a handheld screener that folks could take if we were recruiting in venues, but we have had that translated into an online screener as well. And so now we're up to like 1,900 people have completed that online screener, of which the vast majority said yes, that they would be willing to take a daily pill to prevent HIV. We then brought in 638 individuals. I'm sorry, we didn't bring them in. They were eligible to come in for in-person screening, although we only had 200 slots available. So the demand far exceeded what we were able to provide, but we very quickly enrolled 200 participants into that trial. About 185 made it through the first few study visits in order to start PrEP, and I think that's very reflective of the population we were recruiting, which are young adults who are potentially unstably housed, in and out of school, and focused on many other things other than preventing HIV. And then we have allowed participants who are uncomfortable continuing to take PrEP, either because of side effects that they experience or because they don't feel that they need it anymore. But we keep them on the study, so we're able to follow them over time and say if there was any differences between those who sustained taking PrEP versus those who didn't. And then so far we have 50 participants enrolled in our younger cohort. Most of them have started PrEP, and the only reason that the 5 haven't is because they're just early on in the enrollment process. And our goal for that study is 75. So we have about, we should be ending by the end of August, so we have about 25 more slots left to fill. So if you have anybody, you can send them over. Just to give you a sense that, one of our goals is always really to enroll folks who are most vulnerable to HIV and represent the epidemic, and we've, I think, done a really good job at doing that. We have unfortunately had experience with HIV infection. I had my rose-colored glasses on when we started this trial and said that wasn't going to happen, but it does. I think again, to speak to the very high risk of the youth that we are screening, we found 12 undiagnosed HIV infections at the time of screening. One of the benefits of doing these trials at clinical sites is that we were able to immediately link them into care. And about a quarter of those appeared to be very recent infections, and I say recent infections because either they self-reported a recent negative test, or, as I said before, sometimes it took a long time for folks to get through the screening process, and so we had to test them multiple times, and sometimes we actually had the negative test and then the following positive test, so we knew that it was a very recent infection. We also had 2 participants at baseline that were diagnosed antibody negative and viral load positive. So we did viral loads at baseline just because we didn't want to put anybody on drug who was potentially acutely infected. And in fact, we actually did find 2 participants with that going on. And then unfortunately we have so far had 2 HIV seroconversions on study, one at week 4 and one at week 32. These were participants who were very honest about their struggles with adherence, so we knew they really weren't taking drug. One had moved out of the city for a while and then came back, and when he came back he was infected. But there was no evidence of resistance among these 2 folks. We are following them for seropositive visits. And again, no evidence in their blood that they had currently had Truvada on board. And just to give you a very first glimpse at adherence with this cohort, and this is only the first batch of testing with dried blood spots, and it's only the first half of the cohort, so very, very early days. But what we see is that the vast majority of the participants are trying. This is what I take from this. They're trying and are getting at least probably 2 to 4 doses in a week. So if you remember, that's somewhere between 76 to 96% protection. So some, moderate protection. Can they do better? Absolutely. But what I was actually thrilled about was the very far left column with no drug detected, because what we saw again in those South African trials was that people just weren't taking it at all. And they didn't know that until the end of the trial. And I absolutely did not want to not know that as we were going through. And so what this tells us, which has been our experience with young people all along, is that they really do tend to tell us the truth. The truth is that they're not always taking it, but they tend to tell us that, which is nice. And this is just our website if anybody's interested. So then beyond the kind of current research projects that are going on in Chicago, there are several clinics that have started providing PrEP, and one of them is the Young Adult Clinic at Stroger. John is providing it at Access Grand Boulevard. Howard Brown is providing it. The Core Center is going to be opening a PrEP dedicated clinic, and then there are other private physicians around Chicago that are providing PrEP. We've recently started a PrEP working group, which is being organized by the AIDS Foundation of Chicago, and the Chicago Department of Public Health is very involved in that, and just trying to figure out how we can network across groups, share instruments perhaps, and really kind of get a comprehensive network of PrEP access and programming throughout the city. So what's next for PrEP? There's a lot of energy and a lot of interest in some of the phase 1 safety and the animal models around long-acting injectables. So there are 3 trials that are going to be hitting the field over the course of the next 6 months. One in low-risk women. It's going to be in South Africa with injectable dosing every 8 weeks. One in men and women, which is the GlaxoSmithKline, the VIV product, and that's dosing Q12 weeks. And then the same product in a actually VIV-funded trial, also with dosing 12 weeks. And I think obviously people immediately think, oh, that's the answer to adherence. Long-term injectables. I'll just say we'll see. We have lots of young women on Depo-Provera who do not adhere to their appointment schedule. So. But really, it's nice to be able to look at alternative mechanisms. And some of these, I think that the question is going to be, particularly for kind of thinking about cure research, is the half-life of these products appears to be very long. 6 to 12 months even, you might find detectable drugs still in the system. And this is new from AVAC. This is just showing the rings and gels and films and everything else that's in the pipeline for ARV-based prevention. So we have a lot coming forward, and there's a lot to be excited about. So HIV testing and PrEP programs, I feel that they're just the perfect bedfellows. If you want access to PrEP, guess what? You have to have regular HIV testing, and so I feel that that's going to boost our testing rates. I think it might help us identify more infections than we were previously able to find. But of course, there's always room in the bed for other people, and so we're going to include HIV cure researchers in here and kind of figure out how we can synergize among those things. And so we think about testing. I mean, testing really becomes the key to everything. I really strongly believe that we need more attention, more funding, more focus on our testing programs. Somebody tests HIV negative, certainly they could be referred to a PrEP program. If they test positive, they should be immediately linked to care. Anybody that seroconverts in a PrEP program should obviously be immediately linked to care. And then either from PrEP programs or from care programs, we should be able to link towards cure research. I think we could, in theory, link directly from testing programs into cure research. I think Probably ethically, the push would be to get people directly into care first. But if in whatever capacity that care and those research protocols can be combined, I think we have a lot of potential there. And then just finally, in terms of linkage to care in Chicago, we have several citywide programs specifically focusing on adolescents and young adults. John Schneider leads one looking at the South Side. Rob has one with 3 sites around the city, and as well as the Center on Halsted. And then we have one funded by the ATN. And I just think it's important, I'll just show you that because, again, that's the one that I have data for, that of those that we get reported to us, a large percentage are linked to care and stay in care. But we're still only getting about 1/3 of the cases that test HIV positive linked to these programs. So I think it's important that we're still missing about 2/3 of those cases, and the question is, where are they going? So for future considerations, I think, we heard about Dr. Hitano's, Deb Prasad presented Dr. Hitano's data from Croy around getting the person in the PrEP program into the acute infection protocol. But I think we need to realize that the clinical trials for oral Truvada are finished. So having access to stored blood samples and baseline viral load testing, that's just not going to happen anymore. So we're going to have to think around that a little bit and really be focusing much more on how we're going to recruit from clinical settings and from programmatic settings and care clinics to get into newly infected. Obviously, we need to continue to advocate for the best, newest, and greatest testing technologies, not just in the clinic, but point of care, CLIA waived in the field, 4th generation tests. And then, just as I mentioned before, think about what acute infection and resistance might look like with these injectable, longer PrEP formulations. That's it. Thank you very much.
Okay, and then last but not least, John Schneider, who's going to talk about some of his work on social networks.
Thanks, Rob. Thanks to Rich and Brian for helping organize this. Today I'm going to share a little bit about some of the network approaches to what I think about of HIV elimination. And when I talk about HIV elimination, I mean elimination of new transmission events. So I have support from the NIH, and I've done some advising for Gilead. I'm going to talk a little bit about our Center for HIV Elimination, just real brief because we're behind time. A little bit about network analysis and some of the, I'll give you 3 kind of examples of network interventions as we move into the intervention phase. So we are located here on the south side of Chicago. And kind of right in the middle of one of these heavily hit parts of the city. Most of my work is focused on younger black men who have sex with men that live on the south side of Chicago. So when I talk about HIV elimination, again, it's elimination of new cases. And I think, we have a long-term vision. This is a 30-year, hopefully, vision. That aiming to get this 1,000 cases of HIV in Chicago, down to 800, then 600, then 500. And when we start to get it down to below 500, we're going to be at a point where we can actually start to do more outbreak investigation type of implementation. I don't want to get into dichotomies of elimination versus cure. I think they're both, have to be moving in parallel. They both synergize each other, and I think through this workshop we'll be able to see that there may be some ways to get at. I'm also very interested in the early infection period, and so I think there are ways to get at that prevention cure window, which is right around infection. I think a lot of implementation science needs to be done to really use what we've learned and the tools we have right now to get us to a reproductive rate of less than 1. Just some briefly, I am infectious disease trained. Other elimination programs, smallpox, polio. Some might say, oh, well, they don't carry the stigma, but in fact they do and they have. And so there's been a lot of interest in comparing HIV to other elimination programs. Notably, though, these smallpox and polio elimination strategies did, their core strategy is cocooning. So we kind of identify a case, we look at everyone around the case, and we, prevent the transmission spreading that way. And so that's eventually where we'll get with HIV. Even if we don't have an effective vaccine 30 years from now, certainly there's going to be a lot of tools and ways to mitigate transmission to people who are susceptible. So I'm motivated a lot also by my patients. So I had, this is a case I saw early in my training. Classic 20-year-old young black gay male presents with a rash, no fever. He's diagnosed with acute HIV and syphilis, no drug use, never linked to HIV prevention program, and just, puzzled. But doc, this was the first guy I ever had sex with. And so, as a physician, trying to think about why that may be the case at the individual level, as Brian nicely pointed out, you kind of, not really finding many answers. So that moved me towards sexual mixing. And if anyone, we're all here in Chicago, a book that people should read is The Sexual Organization of the City by Ed Lauman. Really kind of nicely illustrates different sex markets and the way south, west, north sides are different. And this was based on the National Health and Social Life Survey data. Essentially, blacks are more than 5 times more likely to be infected with a bacterial STI, and so the question was why. And as I just mentioned and Brian mentioned, it's seemingly unrelated to traditional risk behavior. Okay, so as you can see here, the population is split into kind of different groups, peripheral being kind of less at risk, adjacent being closer to the core group, which is where there's a lot of transmission going on. And what you can see here is that if you look at the core groups, African American have lower risk than whites, and then Hispanics at the core group, and also less than whites at the adjacent group at individual level behavior. I'm going to walk you through this because it's a little complicated, but it's really 2 important concepts that people should have kind of in their toolkit. We talk about, blacks have sex with blacks and whites have sex with whites, and, people kind of write papers about that. But there are a couple phenomena going on that are network related. So the first that everyone is kind of familiar with is this assortative mixing, which means that individuals have sex with this, assortative means same with same, so sort of homophily. So, the same concept of blacks have sex with blacks. And so what we can see here is that the Hispanic core is 39 times more likely to partner with its own race core than other race core, and the black core is 528 times more likely to partner with its own race core than the white core. So what that means is when I look over here at the African American core, and I look at it compared to the, so African American core is 528 times more likely to partner with the African American core than the white core is to partner with the white core, so 180.4. So basically what this is saying is that blacks are much more likely to have sex with blacks than whites are likely to have sex with whites. And I'll show you a couple slides that help with that for men who have sex with men. But what people don't really talk about is the disassortative mixing. And so this is disassortative mixing based on risk. And so what's also happening in the African American community is that the high-risk African American components, if you have this core, periphery, adjacent structure, the black core, if you look over here, the black core is only 33 times more likely to partner with the black core than when compared to the periphery, okay? But if you look at the white core, it's 180 times more likely to partner with the white core than the white periphery. So what that means is that blacks at different levels of risk are coming in contact with each other more, and there's a number of reasons that we can postulate that explains that. This was some nice data, phylogenetic data that came out of Croy, which kind of just echoes that sentiment that, so if you look at the black MSM, 63% of cases were linked to other Black MSM compared to whites, Hispanic, Latinos, et cetera. And so much more assortative mixing based on race, okay? Another kind of interesting finding, and that kind of echoes this importance to really focus on the MSM epidemic, is because you can see here the other cases that were linked. Certainly, there's a lot of MSM having sex with MSM, but you can also see over here that there are cases linked to MSM in other risk groups. So injecting drug users male, injecting drug users female, heterosexual males and heterosexual females. So impacting the MSM epidemic will not only have an impact on MSM, but will have impact on other risk populations. So I'm going to transition a little bit now to network interventions. So what does that mean? So basically, network interventions are interventions that use network data to define groups. Sorry, we're having a little bit of select change agents. So those are people who enact change in other individuals. Actually affect the network structure. So Brian mentioned like density, so maybe ways to decrease density. Assist behavior change program implementation. And so there are 4 general types that we think about. So one is the change agent model. So we identify a network. We feel that there are people who are centrally located or opinion leaders that might be important people to focus on. And so we recruit those individuals and try and help train them to enact change in their peers. There are other interventions that segment the network and identify groups, and so we have different groups, and within groups we have leaders. We intervene that way. Induction is kind of sort of a community mobilization or network referral process where behaviors just change, and massive testing programs, things like that. That's a network intervention. And then the final is a little more controversial, but the idea of alteration of the network. So we can break chains, we can add chains. This is more commonly done in terrorist networks. We can eliminate, a node or something like that. We're not going to, do that in our HIV networks as much. So I have, I think, just a couple examples of work we're doing, network interventions that I wanted to share. This first one is Project Engage. It's a randomized controlled trial. Actually, Rob Garofalo is also a part of it, where we are identifying HIV-infected individuals in clinics, mostly federally qualified health centers like Access. And we are identifying, we characterize their network, and then we have a process whereby we identify the best person within that network to help them take their medication and help them stay in clinic. So it's a randomized controlled trial. We just finished enrollment, and we are now following them over the next year to see if we have changes in adherence, retention, and viral load. Just the baseline sample. Right now, this is an R34, so it's kind of a preclinical trial. We have some preliminary analysis was just presented that looks at the sexual network proportion stressors. So here are our network proportion stressors. So these are sexual network members who were in jail, who betrayed the trust of the individual, who abused substances. And then we see how that impacted the individual's own behaviors, including medication adherence. And we see when we're looking at the medication adherence, which is really kind of the viral control, certainly there are other important factors like condomless sex and sex drugs. But when we look at the medication adherence, really not much impact that the sex network is having on that. But when we looked at the non-sexual network, so the social network, these could be friends, potentially some family, we see that sort of the chaos in the network did impact some of these other factors, including medication adherence. We have less medication adherence when the network members, social network members, abuse substances, and some borderline findings if they betrayed the trust. So that's sort of a change agent intervention in that category. This next one is the Transmission Reduction Intervention Project, TRIP. This is a 3-site study, Chicago, Ukraine, Odessa in Ukraine, and they're actually doing quite well now, even with all the problems going on there. And then Athens, Greece. In Ukraine and Athens, they're injecting drug users, and in Chicago, we're focused on black men who have sex with men. Basically, what this intervention does is it identifies recently or acutely infected persons, and then it works through their network to intervene with the network. So that includes bringing them in, the network members in for testing and linkage to care if they're positive, but also there's community flyers and other ways that we notify recent networks, recently infected networks, of the potential risk that they may be in. We identify recently infected people by obviously looking for acute infection, but then the limited avidity antigen assay, which can detect recent infection at probably around 6 to 8 months. So here we locate the people with acute or recent infection, recruit the network contacts. The network intervention, we have a kind of an alert where we give the individuals things to pass out to their networks. Some of this can be done through social media as well. Then we identify high-risk venues that these individuals are at, and we can do the same thing at the venue. We can have alerts there. And in Chicago, we are also having the high-risk negatives, referring them to PrEP as part of this intervention as well. This is one of those NIDA Avant-Garde Awards, with the PI being Sam Friedman in New York. These are some very early results. I just, Greece is really the furthest along. So they've identified 37 recently infected injecting drug users. And when you compare the identification of network members within the recently infected networks, you get a greater yield of recently infected persons. And so this is marginally statistically significant. The other 2 sites, we didn't approach statistical significance, but basically the way to read this, the network venue sample is the TRIP intervention, and these other samples are kind of baseline other testing programs. And you can see that definitely in Athens, the yield proportion is larger when we focus on the recently infected network, which kind of makes sense. Odessa and Chicago are a little further behind in recruitment. And the last example is another peer change agent study. Basically, peer change agents, again, people are familiar with the opinion leader model that Jeff Kelly came up with. It was not found to be efficacious when it was expanded multi-center study, but we are looking at new types of peer change agents, so we're thinking other people who have key positions within the network. And so I'll just give you an example of that from Chicago. This is a network of black men who have sex with men, and it's hard to look at this and know who's key or who's not, right? It's just kind of a mass of connections. But when you start looking at sort of a bridging measure, so how bridging someone is within that network, we found that the bridging metric was significantly associated with HIV serostatus in the network. This was cross-sectional analysis, so we don't quite know whether people who are bridges just kind of become HIV infected, or whether people who are HIV infected sort of gravitate towards a bridging position. Regardless, this is an interesting finding because some of these other, I'm sorry, this is an older slide. We have the unprotected anal sex here. But you're going to see kind of actually, I think 2014 will be that shift because same with the compliance adherence story. But anyways, the unprotected anal sex, group sex drug use, not associated with HIV serostatus. So these may be key people to recruit as peer change agents, as we're doing in India. There's a bridging person here, centrally located person here, and we're recruiting these individuals and doing PrEP dissemination. And I think that, so my final thoughts, network analysis is intuitive, it makes sense. I'm a little biased because I'm kind of obsessed with networks, but the epidemiologic data that we have, everything has been focused on the individual as a unit of analysis, and I really think that network level variables need to be included for a number of reasons, which we can go into during lunch. It's important also not to just focus on the risk network, but also the other social networks involved, and we can evaluate multi-level interventions. And I do think that HIV elimination ultimately will be achieved through network intervention. Thank you.
So Rich will tell us how much time we have for questions, because I know we're trying to catch up on some time, but...
Well, I think we'll see how many questions.
Okay, great. Questions from the field? Yeah.
Hi. So I was
Hello.
wondering for the Lurie research with young men, if you're going to be offering PrEP, and this came up at Croy where somebody said, nice observational study, you shouldn't be watching gay men become infected with HIV.
You're talking about our Northwest, yeah, so our cohort study that we're just launching. Yeah, I mean, those are some discussions. We literally just got the notification of grant award, and so I can't give you definitive answers about how we'll be doing that. I mean, I think this, by nature, is an observational cohort, but I think there are really important questions, ethical questions about intervening even within observational cohorts that our scientific advisory board and community advisory board will have to help us grapple with.
So I wanted to hear responses from each of you, I guess, but Sybil sort of brought it up with the Michael Weinstein issue. I get asked the question, well, if people know that they can be cured by taking medicines after they're infected, you know, it's the same thing as taking PrEP, isn't this going to be disinhibiting them? Aren't they going to be taking more risk and having more condomless sex? How do you answer that?
Maybe, but you know, I think again the whole point of the condomless sex is that it may be condomless, but it's not unprotected. And so I think folks that enjoy condoms and have integrated them well into their sexual lives will continue to use them, and those that weren't using them before are going to continue not to use them, and so it's good to have other options. So for cure, should we not have cure? Right, so for cure, should we not have the option? I mean, people are going to continue to get infected. And so should we not have the option available that they could get highly active treatment and be cured?
No, I'm with you.
You know, I think that there's also this level of what are the effects of having options, which is sort of a separate question from what those specific options are. And we did a randomization study where we actually randomized MSM to get combinations of information about different prevention approaches, including PrEP, microbicides, some things that exist and are on the shelf and some that don't. And what we found is actually the more options we described to them, the greater their intentions of actually using condoms were. But also their interest in all of those options increased as well. So, you know, I think there is this sort of meta level issue that options can be really helpful for people, and that it may improve their interest in a range of preventive approaches when we give them options. We have to figure out how to do that, because it's very complicated to message about these multiple options. But I think it's a very productive area of research to think about, do we do if-then messaging where we say, first use condoms, if you can't, then use PrEP? Or do we do, here's a menu of options that are available to you. Do we help them figure out, you know, what's the best option for them? I think that's an area that will be very productive for further science.
Yes.
And I'm sorry, but I have to say, and we just need to stop judging people's behavior, you know, and focus on fighting and curing the disease.
Yeah, and you know, just to get the personalized prevention piece. I mean, you know, there's options, and then there's also agency and ability to make choices. And if people don't have some of those choices to use condoms or not, then you know, there's other options now. So it's really exciting to be able to offer people different options that match their specific context.
I have two questions. The first one is in networks. How much does prison or criminal activity circles impact the retention of untreated, therefore transmission networks? Because in Philadelphia, at least through the zip codes, the ones with the highest incidence, or among the ones with the highest incidence of transmission, are the ones that are within the prison, nearby. And there's this, and because in that environment it's a lot harder sometimes to sustain therapy because they're coming in and coming out. They may be in 60 days out. To what extent is that sort of relevant in this particular city? And the second question is for the PrEP. I mean, there was a lot of concern about the safety concerns of individuals that need not take this drug to be on this drug for a continuous amount of time. And what has been learned from safety monitoring, and what do you actually monitor for? And what has been the experience from that perspective?
So I can take the first question about criminal justice involvement and how that impacts the epidemic, as well as networks. I think, networks, if you just kind of remember, the social drivers of HIV include individual, kind of network, meso level, higher kind of contextual, institutional, structural levels. And so networks fit within that. So if you look at communities that are heavily impacted by HIV, it goes along with high incarceration rates, criminal justice involvement, and similar to the core group. So the core group does have a lot of that, and that goes, they just go together. But one thing to just, it's really not, we think of jails and prisons, but a lot of the transmission is not occurring in the jails and the prisons, and it's really the environment that people are coming in and out of, and the way their networks are kind of having many shocks, and they're getting back with other people or not. And it's sort of that instability which is really driving a lot of the infections, and then other problems, poverty, homelessness, et cetera.
The safety for Truvada focuses on the tenofovir piece of it, and it's the same as we look at in treatment, particularly around bone mineral density, renal functioning. We have seen with tenofovir and PrEP a decrease in bone mineral density. It is statistically significant. It is not clinically significant, i.e. we have not seen an increase in fractures and things like that, but it is something that is monitored, and also being aware of any potential for decreasing creatinine clearance. And so we generally recommend that those levels are looked at regularly as well. But then the other side effects tend to be, the things that go along with Truvada, some nausea, some diarrhea early on, kind of a startup syndrome. And I think also just to say that PrEP is not a lifelong treatment medication, right? I mean, it's preventative. It can be used during periods of your life when you may be at higher risk, may not be in a relationship, are young. But then, just like with birth control, eventually folks go off, or they, change their life circumstances or their relationship sexual circumstances. So I don't think anybody's really thinking of PrEP as a lifelong medication that would cause long-term effects.
Yeah, so to my question, I was really interested in the impact of the penitentiary system on transmission, but one question that remains unanswered: do we have any idea of what the prevalence of HIV infection is in the local penitentiary system here? And if you have any idea as to the frequency of incarceration. So you mapped out really nicely, this is data from the health department, about the prevalence of HIV in various neighborhoods. So if we overlay the incarceration rates, does that match clearly? And the second question I had really relates to the uptick in prevalence or cases that we see in young MSMs. And that started around about, as far as about 2005, 2006, it's been a steady uptick. So there isn't any major difference, at least from your findings, that it's not different behavior on the individual level, but at the level of the network. So do you have any idea from your studies, or any hints or any guesses as to what's changed over the course of the last 7 years that can contribute to this uptick that we see in this specific young population of young men?
Well, I think one potential option is that, I think what we can also look is what's been occurring in the populations where we see decline, and is that same thing occurring in populations where we see increases or stability. I think that we have seen the development and rollout of some very effective behavioral interventions targeted African American women, and we see declines in that population. We have no CDC recommended prevention program for young men who have sex with men. There's not a single one. There's one good evidence one that's more for early young adult men who have sex with men. So we haven't had the prevention response with young MSM that we've seen with other populations. And I don't know, I'm not a sociologist. I'm not really I don't do the kind of work where I could map that sort of response to, changes in trajectories. But I would like to think that that's part of the story. And, the other part of it is, with young people, there's always new young people coming into the world. There's a sort of endless supply of them. And we have to keep educating them, because the young people that we educated 10 years ago are no longer young people, and we have this new batch of them. It's, it's the reality of life on this planet. And so we can't give up, and we can't say we've educated people about HIV, because there's a new group who are coming into their own and starting to initiate sexual behavior. And they struggle with things like even accessing condoms. We just did a national study with rural youth, with rural young gay men, and a lot of them talked about real struggles of even accessing condoms. So there's a lot to be done.
So I just wanted to follow up on Rich's comment and question. And I know all of you are aware of the IPREX study, which is the largest randomized study done to date multinationally among MSMs who are seronegative, randomizing them to receive or not to receive Truvada. And the data there, as I think you all know, but it hasn't overtly been stated here, is that the impact in follow-up of having received Truvada was not an increase in risk-taking behavior, not a decrease in condom use, nor in any other behaviors like drug use that would lead to the risk for HIV acquisition. As a comment that you made, there was also no evidence that among the small number of men who subsequently became HIV infected, that in that study or the Partners PrEP study, that use led to the likelihood of acquiring of transmitted drug resistance with tenofovir-containing drug-resistant virus. And lastly, this whole issue of who's using PrEP. The national surveillance statistics suggest that more women than men are receiving PrEP now. And it's largely women of childbearing potential who are the partners of seropositive men, and they use it as added protection to not get pregnant. So I think these are interesting because it's clearly not the people, the ethnodemographic at greatest risk, which is actually getting prescribed the medication. And some of this might have a lot to do with the fact, we worry about who's going to be, it's not an HIV provider that's going to be doling this out. It's not that person who's going to be monitoring for the nephro or bone toxicity. It's not necessarily that person who's going to be doing the follow-up testing every few months. So these are all sort of framework and infrastructural issues that I think have been challenges to the uptake of Truvada.
Just a caution on the surveillance data around who's taking PrEP. That does not include anybody that's getting PrEP through demonstration projects. So in this country, the vast majority of the demonstration projects are for men who have sex with men. Right. So many of them are getting it through projects, whereas women are getting it through their providers. Right. And
that was prescription data I was talking about.
Yeah.
Last question.
Sorry, just to add one thing about that. I mean, I think I don't know that I would say the nail in the coffin is there about disinhibition as a result of taking medications. I think there's inconsistent data out there, and we certainly need to continue to study how people respond to going on these medications.
So, Sybil, I was struck by the number of adolescents lined up for ATN 110. And your adherence is actually not that bad if you count from 2 times, up to 7 times a week uptake. But yet, what we struggle with in the clinic is these adolescents are covered under their parents' insurance plans, and most of them have not disclosed to their parents of their sexual activity. So what provisions are being made to provide Truvada for these youth who have not disclosed to their parents, are not able to actually get Truvada for protection?
I think it's a wonderful question, Deb, and I think it's something that we need to work out. I mean, first of all, anything under 18 is off-label right now because we don't have the indication down to that. There is provider assistance or medication assistance programs through Gilead, but they are the payer of last resort. And so if they are on their parents' insurance or they can get it some other way, then they're going to expect that takes place. I mean, it is. I mean, outing folks because of their interest in PrEP is a challenge. I don't know, John, if you in your clinical practice.
Yeah, no, it's really hard. Yeah, no, I don't really have much to add. I guess the only thing I would add is geographic area makes a big difference, and so not just for kids but for adults. I think some of these, the way things work in Texas may be different than the way they work here. I'm collaborating with some people there who are not able to get any adolescents, not only through their parents but through some of the other ways that they're paid for in the state. I do think it's important to note, though, that most insurance companies don't provide an explanation of benefits for prescription drugs. So in most cases, young adults or young people can be prescribed PrEP, and if it can be done confidentially the way we do birth control, Depo-Provera, the paradigm there is not much different than the way we provide confidential care in other populations. So I think there are creative solutions. I think it's just the tip of the iceberg in terms of how we do this, but I don't think the paradigm is that much different than in the way we provide confidential services for many other populations. So with that, thank you all for participating.